Research outcome for the partner.
Okay. Good morning, everyone. Today I will present about the CME of the cardiac output physiology. So first, how to define the cardiac output? So cardiac output is the volume of the blood from the left ventricle per minute. So the cardiac output equation.
Ni Kenapa? Oh, sudah boleh.
So the cardiac output equation is equals to the product of the heart rate and also the stroke volume. So in a normal 70 kilo adult, the cardiac output is 5 liters per minute, but it can be increased up to 5 times in exercise. So what is the determinants of the cardiac output? So from the equation, the determinants of the cardiac output is equals to heart rate times the stroke volume. So the stroke volume is the blood ejected from the heart with each contraction. And it has the equation of the stroke volume is end diastolic volume minus the end systolic volume. The end diastolic volume is the maximum amount of the blood in the ventricle before the contraction, where the end systolic volume is the maximum amount of blood in ventricle after the contractions. So this is the end diastolic volume of 120 mils minus 50 mils. So the stroke volume of a 70 kilo adult is 70 mils.
So ini kena ingat lah, it has been asked in SQ past years. Boleh dengar kan kat belakang? So itulah what's the formula for this stroke volume? Is DEDV minus ESV kan? So it's about 70 mils lah of stroke volume.
So the determinants of the stroke volume consists of the preload, the afterload, and also the myocardial contractility. So this is a diagram that simplified the cardiac output comprised of the heart rate and the stroke volume. So the heart volume is the end diastolic volume minus the end systolic volume, while the heart rate is affected by autonomic innervations and also hormones. Another diagrams that simplified the cardiac output equations, factors the heart rate and also factor affecting the stroke volumes. We have the preload, contractility, and the afterloads. These are the factors that will affect the three main determinants will be discussed later. And this is the equations for the stroke volume.
So preload is affected by venous return, kan? How much blood is returned to the right side of the heart, as well as the filling time, isn't it? So kalau venous return je banyak but filling time is reduced, then the preload might be reduced, isn't it? So contractility, on the other hand, is determined by autonomic innervation, maybe sympathetic stimulation will increase contractility and otherwise, as well as some hormones lah, kan? And afterload is determined by the state of the vessels lah, kan? Vasodilation or vasoconstriction. And then preload determine the third layer of the diagram too. Preload determine both end diastolic volume, kan? As well as end systolic volume, isn't it? So which both determine the stroke volume lah. Okay? Contractility influence what? Only the end systolic volume. Afterload pun and systolic volume. Okay.
So for the heart rate, from this diagram you can see that this is the y-axis consists of the cardiac output, and the x-axis is the heart rate, and the y-axis is the cardiac output. So from this diagram, we can see that the cardiac output remain constant or not alter when the heart rate is ranging from 50 to 180s. So at a very low heart rate, which is less than 50, the stroke volume is maximal and is constant because the end diastolic volume of the left ventricle is maximum. And any decrease in the heart rate associated with a fall of the cardiac output. So the cardiac output is now the rate dependent, but at a very fast heart rate, more than 180 beats per minute, there's a short diastolic filling time. which reduce the ventricular filling, and the cardiac output will also drop when there is increase of the heart rate.
So from the diagram, our cardiac output is not affected kan when our heart rate is between about 50 to 170 macam tu kan. Which mean during regular exercise tu, walaupun kita techie, cardiac output not affected kan. That's why we're okay. Tapi bila cardiac output is more than 180 kan, what happened to the filling time? Reduce. So cardiac output pun maybe reduce lah. As well as brady, macam patient dekat ICU tu kan yang die tu because dia ada bradycardia. So bradycardia mungkin cardiac output dia not enough. That's why she cannot sustain life.
So the preload, the definition of the preload is the initial fiber length of the myocardial cells prior to the onset of contraction or the stretching of the cardiac myocytes before the contraction.
So preload apa definition dia? Ada definition lain ke? Volume, isn't it? Kan ada yang volume of blood, apa benda? Isn't it, Sham?
And diastolic.
Kan preload ada beberapa definition yang acceptable. But this is one of it lah. But it's up to your understanding. Kalau you rasa definition ni okay, it's in fact the standard definition. So bolehlah guna this definition. But I think ada a few more version of what is preload. But this one you're saying the initial fiber length of myocardial cells prior to the onset of a contraction. Okay, all right.
So the preload, so the myocardial fiber length, we cannot measure it directly. So the load causing the initial stretching of the cardiomyocyte prior to the contraction of the preload is measured indirectly using the ventricular and diastolic volume. Usually can be estimated by using echocardiography or the ventricular and diastolic pressure from the right side via the right arterial pressure or the CVP pressure. From the left side, we can use the capillary wedge pressure via the Swan-Ganz catheter study. Okay. So this is diagrams that shows the Swan-Ganz catheterizations to measure the pulmonary artery pressure. So we go for determinants of the preload. So
boleh tak kita go to the determinant of apa tu? Stroke volume dulu. I mean, yelah, sekarang we're talking about stroke volume, right? The preload, afterload and contractility. Kan? Bukan you ada next original slide ke? This one.
This one.
Okay, that's up. Go on.
So the determinants of the preload. So first is the venous return. Venous return is the tendency of the blood to return to the heart from the peripheral circulations, and the factors that affect the venous return. We have the equation for the venous return equals to the mean systemic filling pressure minus the right atrial pressure divided by the resistance to the venous return. This follows the Ohm's law. The mean systemic filling pressure normal value is 7 mmHg. For the right atrial pressure is normally 1 mmHg. So the pressure gradient through the veins to the right atrium is the main factor that determine the rate of the venous return. The pressure gradient for venous return is the driving pressure for the blood to flow back into the right atrial is a MSFP, the 7 mmHg minus the mean right atrial pressure 1 mmHg.
Okay, this concept is important lah. Right.
So next is the vascular function curve. This describe the relationship of the right atrial pressure, the mean systemic filling pressure, and the venous return. So what is the mean systemic filling pressure? Is the mean pressure in the systemic circulations that measured without or absence of the blood flow. So the normal value is 7 mmHg, and it can be increased by increasing of the blood volume or by the venous tone, the venoconstriction. So this diagram shows the vascular functions curve. The y-axis is the venous return, liter per minute, and the x-axis is the right atrial pressure, mmHg. So you can see that this is the plateau phase. The plateau phase is that when the right atrial pressure is 0 or more negative, there is no increase in the venous return because of the collapsing of the central vein and also the venous resistance increase. So when the right atrial pressure increases, the X intersection here is where the cardiac output is equals to 0 or the venous return is equal to 0. As the right atrial pressure increase, the venous return also will decreases. So finally, the right atrial pressure is very high that the venous return ceases. So this occurs when the right atrial pressure and the mean systemic filling pressure are equals. There is no driving pressure into the right atrium, and there is no flow here when the mean systemic filling pressure here is the 7 mmHg.
Betul. This concept is you kena balik, you kena be able to explain it to yourself, right? Vascular function curve is a bit complicated, tapi that's why you kena practice. Alright. So where is MSFP? Kat situ kan. It's when the cardiac output 0 and apa yang 0 sebelah lagi? Venous return is 0. And that is during when there is no flow. Keyword tu you kena ingat. So it's about berapa normal MSF? It's about 7, isn't it?
So next is the cardiac function. The cardiac function curve, it shows the effect of the increase in the right atrial pressure will also increase of the cardiac output. So this is the graph of the Guyton graph. It has a vascular function curve and also the cardiac function curve. So this is the cardiac function curve is due to the heterometric autoregulations, the Frank-Starling mechanism. And this relationship between the two curves we refer to as a coupling between the heart and also the peripheral circulations. So the intersection point between the cardiac function curve and also the vascular function curve is known as the equilibrium point. This is where the cardiac output and the right atrial pressure, where the cardiovascular system operates, has a right atrial pressure of 2, and then it will derive a cardiac output of 5. So this is the equilibrium point.
Okay, good. So this is a favorite question in Vivi. So nama lain bagi this curve, what is it? Jangan terkejut pula tanya what is Guyton's curve. So this is the Guyton curve lah. Alright. It has the vascular function curve that we discussed earlier, and as well as the cardiac function curve. Right.
So this is the Guyton curve that occurs in different conditions when there is an increase of the preload or increase of the venous return. So there's a shift of the equilibrium point where the cardiac output is increases from this one to this one, and also the right atrial pressure also will increase. We can see that the mean systemic filling pressure here also increase because of the increase of the blood volume. So this shows the when increasing of the cardiac contractility, the cardiac output is increases from this point to this point, and also but the right atrial pressure here is decreased, and the mean systemic filling pressure remain unchanged when increasing cardiac contractility.
Okay.
So just now mentioned from venous return, we use the formula of mean systemic filling pressure minus the right atrial pressure divided by the resistance of the venous return. So what factors that affect the mean systemic filling pressure? So the mean systemic filling pressure just now already been described. When the circulation stop, pressure equalized throughout the systemic blood vessels. So the pressure is at which the venous return cease is the mean systemic filling pressure, which measure the degree of the filling of the systemic circulations that force the blood back to the heart. So it affected by two factors: the blood volume. Increase of blood volume will increase the mean systemic filling pressure, increase of the venous return. The venous tone, venous constrictions, reduce the compliance of the capacity of the veins, increase the mean systemic filling pressure, and subsequently increase the venous return. So what affected the venous tone is usually increase in the systemic nervous system during exercise or by blood loss. So the right atrial pressure. So what affecting right atrial pressure? First is the atrial emptying or contractions. When the atria contract, it will increase the blood load into the ventricle and also increase the venous return. For the pericardial pressure, so when the pericardium it has a pericardial fluid, it exert pressure and subsequently increase the right atrial pressure and impedes the feeling of the blood from the veins into the right atrium, and subsequently the venous return will reduce. For ventricular contractions, during rapid ejection phase of the ventricular systole, there is a decrease of the right atrial pressure because the ventricular contractions, you pull the AV fibrous spring downwards and it causes lengthening and increasing of the atrial volume and subsequently increase of the venous return. Next is the thoracic pump. So during inspirations, usually we have a negative intrathoracic pressure, and this negative intrathoracic pressure will drive the blood from the extrathoracic vein into the right atrium. It will cause the reduce of the right atrial pressure and subsequently also increase in venous return. So next is the resistance to the venous return. So it has a few factors. The skeletal muscle pump. So when during exercise, there is alternating of contraction and relaxation of the limb of the skeletal muscle. It will squeeze the blood out of the vein to the heart and increase in the venous return. So during exercise, the skeletal muscle pump will increases the venous return. For the posture, from supine to standing position, there's a gravitational pulling of the venous blood, and subsequently the blood will stay at the lower limbs, and this will decrease the mean systemic feeding pressures and also will reduce the venous return. So for the blood viscosity, when the blood is viscous, it will increase the resistance of the blood flow and decrease venous return. When there is obstructions or intra-abdominal pressure, for example, in pregnancy, obstruct the blood flowing back to the right heart, also will decrease the venous return. Next is the autonomic tone, the parasympathetic and the sympathetic tone.
So factors that promote venous return is another favorite question on exam. Most candidates selalu stuck dekat satu jawapan je. Tapi ada banyak factors kan. Skeletal muscle pump, thoracic muscle pump, posture kan. During a supine position, the venous return increase. So many factors. So don't just get stuck with one factor lah. Okay.
So besides the venous returns, there are other determinants of the preload, the ventricular compliance. So increased compliance will lead to the increase of the blood filling, ventricular expansion during filling at a given filling pressure, and this will increase the preload. For valvular disease, AV valve disease will impair the preload because the AV valve, the atriums will cause the blood to stay in the right atrium and it will not flow into the ventricle. So it will impair the preload, and also for the opposite, the semilunar valve disease will increase preload. So the determinants is the atrial contraction. So contractions of the cardiac muscles in the atrium increase the pressure, cause additional blood to flow through the AV valve and increase preload. So patients with IF and also atrial flutter will loss of this atrial. Next is the wall thickness. Increased ventricular wall thickness, decrease preload, for example, in a hypertrophic obstructive cardiomyopathy patient.
Kita boleh go terus sekejap ya. Sebab I ada meeting lepas tengah. Terus kepada next. Lagi. Buat tak payah styling down, tak payah. Lagi. Afterload.
So afterload is the ventricular wall tension required to overcome the impedance to the ejections of the blood from the heart into the arterial circulations. So increase in the afterload will cause decrease of the cardiac output. So the surrogate markers for the afterload is the mean arterial pressure or the systemic vascular resistance that reflects the left ventricular afterload. For the right ventricular afterload, we can measure the pulmonary vascular resistance.
So okay, apa definition afterload? Important definition afterload.
So it's the
ventricular
wall tension.
Ventricular wall tension required to what? Required to overcome impedance of the ejection from the heart. I think ada simpler definition lah, but anyhow it is ada yang kata the work required to overcome pressure kan instead of impedance. We accept a few definitions but must remember the definition of afterload. Okay.
So the determinants of the afterload, we follow the law of Laplace. We can determine the wall stress. So the wall tension is directly proportional to the pressure and also the radius, and indirectly proportional to the wall thickness. So the factors affecting the afterload. Just now we said that the afterload is directly proportional to ventricular pressure. So increase in the ventricular pressure will increase the afterload. So the ventricular pressure is influenced by the systemic arterial pressure determined by the systemic vascular resistance. And we can determine this systemic arterial pressure by the Hagen-Poiseuille law. And from these equations, resistance equals to n eta times length over pi R4 to the power of 4. So the mostly affected one is the radius, is the main factor that determines the systemic vascular resistance. So what affecting the radius is the first, you can see in the systemic sympathetic nervous system stimulation, it can cause vasoconstriction and also increase in the SVR. Myogenic autoregulations reflects vasoconstrictions in response to increase of the wall stretch. Other local metabolites, vasodilation in response to increase of the tissue metabolism, for example, low PO2, high PCO2, and also low pH. So next is the aortic outflow tract resistance. When there is a valvular resistance, increase of the resistance will increase the afterload. Aortic compliance, with increasing of the age, the compliance will decrease, and this increase the afterload. In the intrathoracic pressure, positive intrathoracic pressures, for example, patients on IPPV or with pneumothorax, it can squeeze the heart and increase the pressure gradient between the left ventricle and also the extrathoracic stress. It helps to eject the blood from the heart, and also this will cause decrease in the afterloads. So other factors that affect is from the Laplace law is the radius of the ventricle. So increase of the left ventricular increase the wall stress at any left ventricular pressure and subsequently increase afterload. So Laplace law, there is a increase of the wall stress is inversely proportional to the thickness of the ventricular wall. So thicker wall, it decreases the wall stress by distributing it among larger number of working subhumors, and this will decrease the afterload. So next is myocardial contractility. So the definition of myocardial contractility is the intrinsic ability of the myocardial cells to develop force at a given fiber length, which are not changed due to the changes in the heart rate, preload, or afterload. That means that it is not affected by these three factors. So the index refers to the maximum rate of change of the pressure in the left ventricle during the isovolumetric contractions. Requires catheterization of the left ventricle and high performance electromanometers to measure the myocardial contractility.
Kita tengok terus factors affecting.
The factors affecting the myocardial contractility, first is the sympathetic nervous system. It release of the noradrenalines from the cardiac sympathetic neurons, and this increases the myocardial contractilities through actions of beta-1 adrenal receptors. So changes in the heart rate for the Bowditch effect. So intrinsic myocardial contractility is increased when the heart rate increases. This is because of the increased sensitivity to the calcium in the sarcoplasmic reticulum. So the drugs with the positive inotropic effects, for example, dobutamine, adrenaline, glucagon, digoxin, and drugs with negative inotropic effect, for example, beta blockers, calcium channels blockers, and anesthetic agents. So in disease state, it can reduce the myocardial contractilities, for example, patient in sepsis, myocarditis, ischemic heart disease, electrolytes imbalance, and acid-base disturbance.
I thought you said myocardial contractility is independent of heart rate. Now you say heart rate is one of the factors that affect myocardial contractility. Which one?
Is independent, but this one is in specific condition.
In specific condition.
So positive inotropes, it increased the myocardial oxygen demand and it caused insufficient oxygen delivery and subsequently it caused myocardial ischemia. So for high-risk patients, for example, patients with coronary artery disease, the atherosclerosis will limit the coronary blood flows and it causes ischemic to the myocardium and therefore reduce the stroke volume. So these are factors affecting myocardial contractilities and all summarized in a simple diagram.
Okay, good.
So
All right, tak apa. At this point, I want to summarize lah. Cardiac output is an important topic in cardiovascular system. It's a core topic. So what you have to know according to the syllabus is first the cardiac output and the factors affecting the cardiac output. Okay, so you kena tahu first kena tahu definition of cardiac output. Alright. So and then you kena tahu the determinant of cardiac output, which are. So cardiac output is a product of heart rate and stroke volume. So factors affecting cardiac output are factors that affect heart rate and factors that affect stroke volume. So factors that affect our heart rate are, you cakap ada dua tadi, hormone and autonomic. Autonomic apa? Innervation. Factors that affects SV, stroke volume are preload, afterload, and contractility. So definition. So for the three, you have to know the definition. What's a preload? Define preload. What is?
Single patient of the blood pressure after the feeling of the.
Okay lah, I boleh imagine dalam kepala you ada dia punya imagination, tapi it has to be exact, the definition. Apa, we go back to the definition of preload? It's the myocardial fiber length, kan?
prior to contract,
Myocardial fiber length at the end of initial fiber length of myocardial cells. It bukan just right atrium, Faiz. Prior to the onset of contraction. So kena ingat. So what are the factors that affect preload, Faiz? Ada 6 tadi. Venous return number 1, number 2. Venous compliance. Good. Two dah factors affect venous return dah. Factors affect preload itself.
And also
Approach
disease.
disease. Ada lagi tak yang dia miss? Macam baru 4. Number 1, venous return. Number 2, atrial compliance, betul. Valvular disease, betul. Number 4, atrial kick. Number 5, wall thickness. Number 6, wall thickness. Alright, so afterload definition. Nak pilih orang, nampak siapa ni. Badi you boleh tak? Definition of afterload, what is it? What is afterload? Overcome. Okay lah, lebih kurang lah. Tapi kena exact speed, ventricular wall tension and the wall tension required to overcome impedance to the ejection of blood from the heart to the circulation. Alright, so what are the factors affecting afterload? Pressure. Lagi? Good. Aortic compliance, okay. Intrathoracic pressure, okay. So you fikir daripada ventricle tu mula-mula start dengan ventricular pressure. And then number 2, radius of ventricle, kan. Okay, lagi thickness, samalah thickness ventricular wall. Okay, good. So it's 3 factors, right? Okay. And then lastly, contractility. Siapa nak define? Samaru, what's a contractility? Myocardial contractility. Intrinsic ability of the, yes, to develop force, kan, at a given length. So kena ingatlah, it is not due to changes in heart rate, preload or afterload. Yang tu kena masukkan juga dalam definition. So factors affecting myocardial contractility, Kamaru? Parasympathetic lagi. Dalam physio, drugs letak last sekali Number 2 is the circulating catecholamine lah kan. Yang lain-lain macam disease or drugs kan. Disease dengan drugs letak kat jawapan dekat bawah sikit. Okay. So that's it lah. In essence, saya kena tahu what definition cardiac output, berapa normal value, what are the determinants and the formula, and the factors that affect each of the determinant. Right? And also you kena tahu according to syllabus what is it I asked French-Starling mechanism. Ada masa nak go through today, and also the life and curve lah, the cardiac output and ventricular function curve. Alright. So can we go to the SBA just quickly? French-Starling, kita skip lah, kita tak sempat cover yang lain. Okay, betul juga. Okay. Next. The left ventricular wall stress or tension is a determinant of myocardial oxygen
Utilization. Which of the following changes will reduce the myocardial oxygen demand the most?
Sekejap left ventricular radius will reduce myocardial oxygen demand. Increase left ventricular radius. Increase pressure will increase demand. Increase ventricular wall thickness will increase demand. Stroke volume will demand. Lah kan? Kenapa C?
Because according to the Laplace law, the pressure wall tension is directly proportional to the pressure and also the radius, and inversely proportional to the left ventricular wall thickness.
Okay, tak apa. Next. Left ventricular function. Ni apa jawapan dia? Left function is independent of preload. Which of the following
Assessment of the left ventricular function is independent of the preload and afterload?
D kan? Maximum DT, betul tak? Salah.
Because the end systolic elastin is the index of the contractility is independent of the preload and also the afterloads.
Okay. Okay lah, next.
Increase in which of the following parameters will cause decrease in the cardiac output?
C lah, afterload kan. Okay, good.
So venous return may be augmented by
B. Alah. Resistance.
Resistant.
Speed. Okay.
So positive pressure ventilation and PEEP can affect the venous return. Which of the following mechanism explain how PPV and PEEP may increase the venous return?
Yeah. Betul tak?
Intrathoracic. Jawapan dia A. Increase of the intra-abdominal pressure. Because PPV increase the intrathoracic pressure and the right atrial pressure, but decrease the gradient of the venous return and result in decrease of the RV filling. However, PPV and PEEP also have an effect by causing the diaphragmatic descent into the abdomen. The abdomen is store of the venous blood, and diaphragmatic descent lead to increase of the intra-abdominal pressure and subsequently increase the venous return.
All right. Next. Okay, go on.
So past year in 2012, so it has a pressure.
Ni masa tahun saya ambil first year kot, 2012
And also physiological mechanism involved in the increasing cardiac output.
So that's why determinant cardiac output important. Tapi first dalam marking you jawab dulu cardiac output is apa kan? It is the product of heart rate and stroke volume. So cakaplah kan, divide satu-satu. Heart rate apa yang determine? Macam tadilah. Okay. Physiological mechanism involved in increasing the cardiac output. Yang ni nak jawab macam mana? I think we go satu-satu lah kan. To increase the cardiac output, we must increase the heart rate kan. Then must increase the stroke volume, must increase the contractility. Itulah satu-satu lah. Okay.
So
Same question. 10 years later.
determinants of the cardiac output and discuss mechanism by PPV affect the right ventricular output and effect of PEEP on the renal perfusion and splenic perfusion.
Oh, I remember this.
So this is the examiner reports.
Ramai pass 70%.
70% pass. So we start to explain determinants, start with the equation, and also explain about the preload, afterload, and contractility.
Okay, next.
October 2023, define left ventricular afterload, defines the factors affect the left ventricular afterload and demonstrate and explain effect of increased afterload on LV pressure volume load if inotrope remain constant.
Yang ni susah sikit lah sebab dia tanya spesifik about afterload.
So this one also, I think most of them pass around 70%.
70% juga. Sepatutnya you baca lah examiner's report Next.
Next, in
Any recent,
April
any recent,
24.
yeah.
So the following volume measured from patient's echocardiogram. The left ventricular end diastolic volume is 120. Left ventricular end systolic volume is 40 mils. So we need to calculate the stroke volume and also the ejection fraction.
So macam nak calculate ejection fraction? Ah, lepas tu? Okay. So berapa tu EF dia? 60%. A few seem not to be able to calculate simple mathematics, which do not require calculator.
So the next one is the list the determinants of the stroke volume. Define and briefly describe how each determinant lead to increased stroke volume and outline how the stroke volume would change in elderly.
So like kata stroke volume kan, ada banyak determinants dia kan. Tengok jawapan dia. Majority were able to sum description. Marks are awarded. For the definition of each determinant tu kena bagi definition. Okay? And the stroke volume itself. So can you simply equate venous return with free load? It's not equal, it's only one of the factors. It's in fact two different things. What else? Atrial cardiac valve. Okay.
It's all mentioned in the slide just now presented.
Yeah. Okay, good. Alright, any question? Ni untuk apa sebenarnya ni? Oh iya ke? Kalau tak, dia orang tak dengar sangat lah. Kan? Alright.